Okay, welcome back to Pierce Pain Relief. We're now in week 11. We'll be covering Microbiology Part 3 and Pharmacology Part 3. So I'm going to start off by talking about antimicrobial resistance and transfer. So what is antimicrobial resistance? It occurs when microorganisms such as bacteria, viruses, fungi, and parasites change, thus rendering the chemotherapeutic agent used to kill them ineffective. So antibiotics, antibacterials, antivirals, antifungals, antiparasitics, they become ineffective when the microorganism changes in response to it, and that's what causes antimicrobial resistance. So obviously, antimicrobial resistance is a big concern because patients infected with these strains may not respond to treatment. And furthermore, resistant infections can kill, spread to others, and pose huge consequences to healthcare and society. Antimicrobial drugs also express selective toxicity, so they target unique structures in microorganisms that are not present in human cells. So talking a bit about antibiotics now, there's 5 major targets of antibiotics usually. So first, antibiotics may inhibit cell wall synthesis. So drugs like penicillin, cephalosporins, vancomycin, isoniazid, or ethambutol. These are the group of antibiotics that will inhibit cell wall synthesis and eventually cause the bacteria to lyse. Antibiotics can also inhibit protein synthesis, so macrolides and tetracyclines. They can also inhibit nucleic acids, so DNA or RNA synthesis, so drugs like rifampicin. They can also inhibit metabolic pathways, so trimethoprim. And they can also disrupt the cytoplasmic membrane. So then how do bacteria become resistant to antibiotics? So some bacteria have innate resistance to antibiotics. Some antibiotics may alter the target site. They may also alter access to the target site. And also have alter the uptake of the drug. And some bacteria can actually modify or destroy the antibiotic agent. Okay, so innate resistance to antibiotics. So you should have learnt by now that gram-positive bacteria have a thick peptidoglycan wall. So the reason why gram-positive bacteria stains purple is because of this thick peptidoglycan cell wall, because the purple dye sticks to it very well, whereas your gram-negative bacteria have a thin peptidoglycan wall. And this is why it usually stains pink, because the purple dye doesn't stick well to the thin wall. And also gram-negative bacteria have an additional outer membrane with lipopolysaccharides attached to it, so LPS, and you can see here, gram-negative. You can see that it's a thin peptidoglycan wall compared to your thick wall in gram-positive bacteria. And there's also an outer membrane and your lipopolysaccharide layer. So the outer membrane of gram-negative bacteria is, the outer membrane of gram-negative bacteria is impenetrable to vancomycin due to the LPS layer. So because of the layer of lipopolysaccharides on gram-negative bacteria, vancomycin can't actually destroy gram-negative bacteria, and that's why we say that gram-negative bacteria has innate resistance to vancomycin. Additionally, some gram-negative bacteria also have an additional layer of very waxy mycolic acid, which is impenetrable to drugs like penicillin. So the drug cannot reach the peptidoglycan layer to break down the bacterium. So penicillin usually works by cleaving the peptidoglycan wall, but because of the presence of mycolic acid in some bacteria, so for example, Mycobacterium tuberculosis have a mycolic acid layer. Because of this layer, drugs like penicillin cannot reach the peptidoglycan wall, and therefore they cannot break down the bacteria. Okay, moving on to acquisition of antibiotic resistance. So through random chromosomal mutations, some bacteria can alter the target site or access to the target site of an antibiotic. So a change in base sequence of DNA can result in a permanent heritable change in genetic material that helps bacteria evade effects of antibiotic. And this can occur if a patient doesn't finish their course of antibiotics and or if the dose is too low. This is because only a portion of the bacteria will be killed, and then the proportion that was not killed may acquire genetic resistance, and then they will multiply. So you can just see in this image here, say that you've had too low of a dose of antibiotic, so it only kills off a certain number of bacteria present, but you still have some bacteria that are alive and that can replicate. And if it happens that some of the bacteria that underwent a mutation to gain antibiotic resistance are still alive, they can replicate, and a whole like new generation of resistant bacteria is kind of given. So antibiotic resistance can be obtained by taking up resistant genes from other bacteria as well. So there's kind of three mechanisms you need to be aware of. So the first is transformation, which is the uptake of external DNA. So for example, a live bacterium next to a dead bacterium may have mechanisms to engulf debris and pick up genetic material. There's also conjugation, where there's DNA transfer between two bacteria via a structure called a sex pilus. And you also have transduction. So here you have a bacteriophage, which is a virus that affects bacteria, inserting resistant genes into a bacterium. You can see just in this image here, showing you what transformation would look like, what conjugation would look like, and what transduction would look like. Okay, so antibiotic resistant genes can produce enzymes that degrade the antibiotic. So here, your antibiotic degrading enzyme. You can have enzymes that alter the antibiotic so that it doesn't affect the bacteria anymore. And you can also have efflux pumps that pump out the antibiotic when it enters the bacterium. So antibiotic comes in, because of the efflux pump, it pumps back out and it doesn't affect the bacteria anymore. So just a bit more about the genetic basis of antibiotic resistance. So plasmids are circular DNA molecules separate to bacterial chromosomes. So in your bacterium, you'll have the bacterial DNA, and you'll also have plasmids. They're not to be confused with each other. So plasmids are self-replicating, and they can be transferred between bacterial cells via conjugation. So conjugation, remember, the transfer of DNA via the sex pilus. So this kind of like bridge link here is what is the structure called a sex pilus, and here we see bacterial cells undergoing conjugation. Okay, so plasmids carry genes that encode for the control of their replication, resistance mechanisms, virulence genes, metabolic enzymes, production of antimicrobials, and conjugation factors. So you can see here, this is an example of a plasmid, of a resistance plasmid, so R100, that contains multiple resistance genes. So it's resistance to tetracycline, sulfonamides, etc., etc. This affects the uptake of the drug, and it also inactivates the drug. It can also move a copy of the plasmid to a new bacteria via conjugation again. Then both bacteria will become resistant. Okay, so also transposons, so jumping genes. Transposons are mobile genetic elements that transfer DNA within the cell, often carrying resistance genes. So it can be plasmid to plasmid, plasmid to chromosome, or chromosome to chromosome. So a simple form of transposons are insertion sequences, or IS elements. So on insertion sequences or IS elements, you have two inverted repeats on either side of the target gene, usually 14 to 40 base pairs long. So you see the yellow part here, IR, for inverted repeats. It's on either side. And then in the middle, you have a target gene that's usually 150 to 1500 base pairs long. And this will usually encode for the transposase enzyme, which catalyzes transposition processes. And a more complex version of a transposon are composite transposons. So here it's just, you have two IS elements on either side of the central region. And then the central region will contain multiple genes for antibiotic resistance, virulence factors, and etc. So you can see here, again here, this is just your simple transposon, so your IS element. And your composite transposon will look like this. So it will have two insertion sequences on either side, and then other genes is where your multiple genes go. So here again, another diagram. So this kind of like light coral color represents your IS element, and then you can see here there's like 4 different genes. So you can imagine the danger if a transposon carrying antibiotic resistant genes jumps onto a conjugative plasmid, which can then further be moved into more bacteria. So then you get bacteria that's resistant to a lot of different things. There's also non-genetic bases of antibiotic resistance as well. So for example, bacteria can be walled off within abscess cavities, so the drug actually can't penetrate it. Bacteria may also remain dormant in tissue for many years. So an example of this would be Mycobacterium tuberculosis, which can remain dormant. Bacteria can also lose their cell wall and survive as what's called a protoplast. And therefore it becomes insensitive to drugs targeting the cell wall. Presence of a foreign body such as surgical implants or catheters also makes antibiotic treatment difficult, and bacteria can also form a biofilm which is hard to penetrate. So what are some practices leading to antimicrobial drug resistance? So first of all, the overuse of antibiotics in medicine, agriculture, and veterinary practice. Because remember that the use of antibiotics provides a selection pressure on the bacteria. There's also the incorrect use of antibiotics in medicine. So things like the wrong choice of drug, the wrong duration or the wrong dose, and also unnecessary overuse once again. Because insufficient dosage leads to resistance, and you must always finish your course of antibiotics. And finally, ineffective infection control measures. So, for example, not washing your hands properly. Some examples of multiple resistant bacteria, or MRB, so bacteria that's resistant to more than one drug. So in the hospital, what's common is MRSA, which is methicillin-resistant Staph aureus, vancomycin-resistant Enterococci, VRE, and multi-drug resistant MDR, gram-negative rods. In the community, you have S. pneumoniae, H. influenzae, S. aureus, N. gonorrhoeae, Salmonella shigella, and M. tuberculosis. So focusing a bit more on MRSA, a bit of history. So penicillin was introduced in 1943, and due to the unregulated use of antibiotics, Staph aureus was over 80% resistant to penicillin by the 60s. In 1959, methicillin was introduced, and then in 1961, we saw the first strain of MRSA evolved. Vancomycin has been available since 1958, and then in Japan in 1996, we saw vancomycin intermediate, Staph aureus, so VISA, which have reduced susceptibility to vancomycin. And nowadays, we have also vancomycin resistant Staph aureus, VRSA. So MRSA is a common nosocomial pathogen around the world, and you'll learn a lot later in your studies that MRSA is a cause for a lot of complications in the hospital setting as well. So nosocomial means from the hospital. MRSA is particularly difficult to treat because, and vancomycin is often the only drug of choice for severe infections, and MRSA is easily transmissible between patients. So finally, what can we do to prevent antimicrobial resistance? Well, first of all, we can prevent infections and the spread of infections. So things like hand hygiene, public education, and vaccinations all help to prevent infections and to help prevent spreading them. As health professionals, we can also track resistance patterns. So we can send specimens for diagnostic and antibiotic susceptibility testing. We can also improve the use of antibiotics. So instead of choosing broad spectrum antibiotics, if we know what bacteria is involved, we can choose the narrowest spectrum antibiotic required. And most importantly, we do not prescribe antibiotics for viral infections. And also we can develop new antibiotics and diagnostic tests.
Hello, Jaffies. Today I'm going to take you through the core antibiotics which you guys need to know for year one. Here we go. So first of all, let's have a quick look at how we can classify our antibiotics, and this might help us in approaching them for study. So we can classify them by the class of drug that they are. So this is usually based on their molecular structure. For instance, penicillins, there's lots of different drugs under this category, and same with cephalosporins. And these guys actually fall under an even larger class called beta-lactam antibiotics, which target particularly gram-positive cell walls. So this is an example of one way that we could classify drugs. The other way that we can classify them is based on their spectrum of activity. Some drugs attack a wide range of bacteria, and some are really specific to a certain group of bacteria or even just one species. So spectrum of activity is important to know. Finally, we can classify them on whether or not they're bactericidal or bacteriostatic. So bacteriostatic, that means that we're not killing the bacteria, but we're stopping them from dividing. So their growth stagnates, their multiplication stagnates, and the immune system is responsible for eliminating them. In bactericidal antibiotics, the antibiotics actually kill the bacteria actively. So the immune system is just responsible for clearing up whatever's left over. Now, I'm going to go through this later, but it's important to note that bacteriostatic doesn't mean worse, okay? Just because it's static and doesn't kill the bacteria, that doesn't mean it's undesirable or less powerful, because sometimes bactericidal is actually not good. We'll talk about examples of that later. So I've got a nice little table here. I know med kids love their tables, just summarizing all of the different drugs. And we're going to learn about these guys individually in just a moment. So don't worry if this table is a little bit stressful. Yeah, there's a little bit more, I know. But even though it looks big, there's only 13 drugs here. So I promise you guys, you can do this. The hardest part is going to be getting started if you haven't already. But I promise you, once you get the ball rolling, it'll be easy. And here's a little guide that I've given you guys as a hierarchy for the things that you should know. I would say that you absolutely need to know the drug names. So you need to know gentamicin, vancomycin, ciprofloxacin. You have to know those guys. You don't have to know the classes. You need to know the names. You should probably know what their targets are, or at least what they're doing. So for instance, you may not need to know that vancomycin targets peptidoglycan precursors, but you should know that it stops cell wall synthesis. We also need to know very important side effects and contraindications. So not every contraindication or side effect under the sun, but the most important ones, serious ones, or especially common ones. Also, we need to know the spectrum, but this is lower on our priority list, okay? Now, before we begin, I've listed the special features. This is contraindications, this is fun side effects, and it should be noted that for pretty much every antibiotic ever, GI upset, so gastrointestinal upset, is a side effect. It doesn't occur all the time, but it often occurs. So that's worth noting. I haven't listed it every time because it would be too tedious. But know that GI upset can be caused by pretty much any antibacterial. Here we go, okay? Beta-lactam antibiotics. So we've got penicillins and cephalosporins. Now, beta-lactams are special antibiotics that target these transpeptidase enzymes, which are responsible for assembling peptidoglycan into cell walls. So by blocking those enzymes, it inhibits peptidoglycan cell wall synthesis, and because the bacteria can't make a proper cell wall, their cell wall's weak, they lyse, they break, they die. Bactericidal. Now, because they attack peptidoglycan, which is a key feature gram-positive bacteria, these guys are especially effective against gram-positives and not so good against gram-negatives. Oops, sorry. Special features that we should know about, as you may already know, penicillins may cause allergy. So there's a fair proportion of the population that are allergic to penicillins and need to be prescribed different antibiotics. By the way, you probably shouldn't prescribe cephalosporins to someone who's allergic to penicillins because they're both beta-lactams. So they both have a similar chemical structure, even though their class is slightly different. Now, as a side note, these guys are often co-administered with this thing called clavulanic acid because bacteria have developed these enzymes called beta-lactamases, which are designed to destroy the antibiotics because they destroy the beta-lactam ring. So clavulanic acid is a beta-lactamase inhibitor. It binds to the bacterial enzyme that breaks down these guys. So the bacterial enzyme can't break down the antibiotics, and now your antibiotic is free to go on and kill the bacteria easily. Okay, then we've got tetracyclines. These are a very, very broad spectrum antibiotic. So they can kill quite a few gram-positives and gram-negatives. They can kill chlamydia bacteria, which don't fall into either category. They can kill rickettsia bacteria, which again don't fall into either category. But the only one they can't kill is TB, which falls into the category of mycobacteria. Now, these guys, how do they do it? They bind to the small ribosomal subunit. So there's two units, a large and a small, and they bind reversibly. Now, what you'll notice is, especially with ribosomal binding, when something binds reversibly to it, that agent tends to be bacteriostatic. And when it binds irreversibly, it tends to be bactericidal. And you can kind of imagine why. If it was binding reversibly, then it might fall off, and then the bacteria can still use its ribosomes. Okay, so what do we use it for? Well, it can be used as an antibiotic, of course, but it's also used as prophylaxis for malaria and as treatment for acne. So it has antiprotozoal activity, and it can attack some of the bacteria that contribute to acne. So then and as I've mentioned, it's got a huge spectrum. It's good for pretty much everything except tuberculosis. What are some special features about this guy? Well, besides its massive, massive spectrum compared to most antibiotics, it has some nasty side effects. So it can cause photosensitivity, which is either you don't want to be in sunlight, or you can, like, your skin is more sensitive to it, so you can get burnt more easily. It also causes tooth discoloration. Now, this is especially significant in late-term pregnancies and in children under 8 years old, because it's the fetus whose teeth and bones are developing that's at risk, or a child that's under 8 years old whose teeth are still developing. So we don't prescribe doxycycline to pregnant women past 18 weeks or in children under 8 years old because it might damage the teeth or the bones. Now, then we've got our aminoglycosides. We only need to know gentamicin. This guy binds to the small ribosomal subunit, so it binds to the same part as doxycycline, but it binds irreversibly. And remember what I said, reversible tends to be bacteriostatic and irreversible tends to be bactericidal. Now, gentamicin is good against most gram-negatives and some gram-positives. So when you consider it, it's a fairly broad spectrum antibiotic. And its special features, well, you'll find that it shares these features with one other drug called vancomycin, which we'll learn about later. It is very toxic to your kidneys and to your inner ears. And so it should be used in caution in most patients, and this kind of includes pregnant patients, but the main antibiotic that is contraindicated in pregnancy is still doxycycline. So this isn't necessarily contraindicated. These are just some effects that may occur. They're just less likely. Then we've got our macrolide antibiotics, clarithromycin and erythromycin. You need to know both of these, but they functionally do much the same thing. They bind to the large ribosomal subunits, so different to gentamicin and doxycycline, but they do bind reversibly. So again, they're bacteriostatic. Now, they have a very similar spectrum to penicillin, so they're a common alternative for people who are allergic to penicillin for obvious reasons. Then we've got our antimicrobials. So we have a first line attack against tuberculosis. And this is this tetrad of drugs. Sometimes pyrazinamide is not included, I think, or sometimes it's only 3 instead of 4. But the ones that we absolutely need to know, isoniazid and rifampicin. in pretty much every combination, these guys will be co-administered. So what do? Well, rifampicin binds to RNA polymerase, and that stops RNA from being synthesized. And without RNA, the TB bacterium can't make its proteins, so it's bactericidal. Isoniazid inhibits mycolic acid synthesis. Now, we learned that peptidoglycan is the main cell wall component of gram-positive bacteria, but mycolic acid is the main cell wall component of tuberculosis bacteria, or Mycobacterium tuberculosis. So by inhibiting the synthesis of that, isoniazid works similarly to the way that penicillins and cephalosporins work. It just works in TB instead of in gram-positives. Now, the only difference is that it may be bacteriostatic because TB is very, very slow growing in most cases, but it may be bactericidal if the TB is a little bit faster growing. Again, usually co-administered. Now, rifampicin has a special feature because it actually causes your urine to become very dark and orange. So the way I remember that is rifampicin, so your piss becomes red or orange. Quinolones, so we need to know ciprofloxacin. Okay, now this guy binds to DNA gyrase. Now, gyrase is a bacterial enzyme, which is a type of what we call topoisomerase. Now, you may have learnt about that when you learnt about the central dogma, but you may have forgotten. It's a pretty kind of obscure enzyme. Its job is basically to stop DNA from getting too coiled up. And if it gets too coiled up, then the DNA might break, or it becomes very hard for enzymes to do their job and replicate the DNA. So if the point is, you don't want your DNA to get too coiled up. So essentially, by blocking DNA gyrase from doing that, the ciprofloxacin makes the DNA get too coiled up, especially since the DNA is being replicated. You're stretching apart the strands and you're making the helix tighter and tighter by pulling them apart, so that so the DNA eventually breaks. And as a result, because this is irreversible binding, it's bactericidal. Oh, sorry. Now, there are some special features of this one. It has a pretty nasty side effect. In this case, it really weakens muscles and tendons. Now, the way I remember that, and also what it's contraindicated in, is that ciprofloxacin, proflex, so flex being like muscles and tendons, you think, and pro being pro-athlete. So you can kind of think, athletes use their muscles and that kind of thing. You can kind of link it that way. So you don't want your athletes to snap their tendons, because sometimes they like the Achilles tendon might be more at risk. So you would avoid prescribing ciprofloxacin to an athlete or to anyone who has to do lots of physical work. We also don't give it in myasthenia gravis, which is a neurological condition which causes more muscle weakness again. Glycopeptides, I mentioned vancomycin earlier. It's a bit similar to gentamicin, not in the way that it acts, and not in the bacteria it targets either, but in its nasty side effects of kidney toxicity and inner ear toxicity. Now, it has a completely different spectrum because this is a guy for gram-positives. It binds to these peptidoglycan precursors and inhibits cell wall synthesis. So it has a similar way of working to cephalosporins and penicillins. Now, we often use vancomycin in methicillin-resistant Staph aureus, and the reason for that is that, well, it's methicillin resistant. So penicillins are no good against a lot of Staph aureus, especially the Staph aureus that's found in hospitals. So vancomycin is one of the drugs that is a candidate for treatment of MRSA. It's also good for other gram-positives because of its mode of action. Vancomycin has one side effect which is kind of unique to it, and that's called red man syndrome. Basically, people kind of get a little bit allergic and they release a massive amount of histamine into their bloodstream, and so they go quite red and swollen, and it's similar-ish to an allergic reaction. Then we've got nitroimidazoles, so metronidazole. This guy messes with DNA, preventing the synthesis of nucleic acid, and if you can't synthesize nucleic acids, you can't synthesize proteins, you can't replicate, so it's bactericidal. Now, this guy is actually both antiprotozoal and antibacterial. So It's especially good against anaerobic bacteria though. Now, its special feature, it causes metallic taste in the mouth. So metronidazole, metallic. It also has a nasty interaction with alcohol. And finally, we've got our folate pathway antagonists, so trimethoprim and sulfur drugs. Trimethoprim is a mainstay drug for UTIs. So as soon as you hear trimethoprim, you want to be thinking UTI straight away. It's almost exclusively used for that. Then we've got what does it bind to? It binds to dihydrofolate reductase. And as a result, because these guys are inhibiting the folate pathway, they're both bacteriostatic, because folate is and folate synthesis is really important for DNA replication. So if you can't replicate, then you're not going to divide. Interestingly, though, if you co-administer these drugs, you actually get a bactericidal result. So often trimethoprim is co-prescribed with sulfonamide. All right, that's the last of our drugs. So we've got a little quiz for you guys. So which antibiotic is contraindicated in pregnancy? Now note, you would use all drugs with caution in pregnancy, but there's one antibiotic that is absolutely contraindicated, especially in late-term pregnancy. So I haven't put in late-term pregnancy, but you can remember that side note if you like. It's also contraindicated in children who are under 8 years old, this drug. So I hope you've had a good crack. Let's have a look at the answer. If you said doxycycline, congratulations. And if you didn't say doxycycline, no worries. It's pretty tough with 13 drugs in one swift lecture. There's plenty of time. I'm sure you guys will get there. All right. So which antibiotics may cause ear damage and kidney damage? So there's two main ones. I've given it, oh shoot, I shouldn't have said that. Oh well, there's two anyway, so it's going to be FG or H. And you might remember it by some mnemonics, but I personally always remembered it by their endings, and then I just exclude the macrolides. Macrolides don't do it. And that may have given you some good hints. The answer is B and E, vancomycin and gentamicin. And so mycin ending, that's the one I think of. And so that I don't include clarithromycin and erythromycin, I remember that those guys are macrolides, and macrolides don't cause nephrotoxicity and ototoxicity. They're pretty safe. They're much like penicillins. And then the last one, which antibiotic or antibiotics should be avoided in athletes or laborers? I won't say anything. All right, if you guys said ciprofloxacin, then well done indeed to you. You guys have obviously picked up a lot, and yeah, good on you. And again, don't worry if this is all news to you guys, because there's plenty of time, and you guys have really been doing it tough in the time of COVID. So absolutely no need to worry if you're not getting it now. Plenty of time to learn. I hope these resources are useful for you guys. All right, catch you later.
I'm going to take you over antivirals this week. So I'm just going to go over antivirals in general, and then a little more about ART in particular, which is used for HIV, and lastly, just the core drugs. So viral diseases, so most of them are actually self-limiting. It's not that hard to get rid of them with our own immune systems, provided that we're nice and healthy. And we'll see that antivirals actually only exist for some diseases. And the reason behind this is that they're actually a lot more difficult to target compared to bacteria. And the reasons that they're more difficult to target is first that they replicate using our own host cell machineries. So to target these machineries would be targeting our own cells as well. So instead, we have to try and target viral-specific proteins instead. So they're the same things that may exist in our bodies, but they're viral-specific. And it's also because viruses have a broad spectrum of activity, thus we just can't produce a drug that targets many. Instead, we can only make specific drugs that targets like one specific mechanism. So our current available drugs are only virostatic. So like bactericidal, it's only virostatic. So this is because we can only hit the viruses that are actively replicating, But as we know, for viral diseases, oftentimes the virus may remain dormant or latent in our cells, and when that's the case, we can't target them. So it's kind of up to our immune system to try and get rid of the rest. That's why the host immunocompetence is important, and for those with for those immunocompromised, like the elderly, or like HIV patients or whatever, they need to be on drugs long term. So antiviral targets. So to the right, top right, we see this is the viral replication cycle, and proteins are involved in every step of this replication cycle, and we can see that's why we have all these different drugs to try and target as many of these specific steps as we can. Yeah, and antivirals are quite specific in the process they target. So these processes are like viral attachment and entry, penetration and coding, early protein synthesis, nucleic acid synthesis like DNA synthesis, RNA synthesis, late protein synthesis and processing, so like transcription, translation, stuff like that, packaging and assembly, and viral release. Yeah, and antivirals are classified according to their primary clinical use, or like the family they try to target, or their mechanism of action. And we tend to classify antivirals and antiretrovirals slightly differently. Okay, so adverse effects. The adverse effects of most antivirals are pretty well tolerated. We may experience headaches, malaise, fatigue. Some have dose-limiting toxicity, meaning that, we just can't take too much of it. And a lot of them also have drug interactions, especially once they're taken chronically, such as HIV, Hep B, and stuff, because some viral diseases are very chronic. Yeah, and they can also interfere with the metabolism of many conventional medicines. Yeah. And antiviral resistance. So viruses mutate really, really rapidly. So resistant genotypes normally have mutations in one or more of their genes that encode for protein targets, and they can sometimes become the dominant strain in someone undergoing treatment, and resistance is relative. So drugs normally target a single protein, like I've mentioned before. That's why we like to use combinational drug therapy to try and avoid like resistance, stuff like that. Yeah, and to this right is this table that was found in the lecture about all the different like virus families, infections they cause, and the different type of drugs. But I'd say don't be too concerned about this, as just focus on the core drugs, which is coming towards the end. Yeah, so HIV and antiretroviral therapy. So in antiretroviral therapy, the CD4 count and the viral load is important, and they're used to determine when to commence treatment. So there are guidelines about like where the CD4 count is and stuff like that, and is also used to monitor the disease and response to treatment as we go on. Yeah, and viral load is like measured as the number of HIV RNA copies per milliliters. Yeah, and the overall aim of antiretroviral therapy is to achieve maximal and durable suppression of viral load. And this also reduces transmission. So that's why you can hear about like most HIV positive patients, as long as they're taking the right drugs and stuff, they they're safe to be with and stuff like that. Yeah. And we try and restore and preserve the immune functions of these patients, because as we know, HIV causes damage to your immune system until you can no longer protect yourself. So by compressing this, we try and preserve the immune function and resolve symptoms of HIV infections like weight loss, diarrhea, stuff like that, and improve the quality and length of life. So nowadays, HIV positive patients can live a pretty long and normal life, and also reduce HIV-related mortality. So today, there are over 30 different approved HIV drugs. They're the nucleotide reverse transcriptase inhibitors, non-nucleotide reverse transcriptase inhibitors, protease inhibitors, entry inhibitors, integrase inhibitors. And I think the first 3 appear in your core drug list. And combination therapies are often preferred. So we use more than 3 drugs from 2 or more classes. Like we said, this is to effectively target the virus and also reduce the chances of resistance. Yeah. And we also have a lot of fixed dose combination medications. So there's you could probably find online a list of all these different combinations that are used. And we can use drugs from the same class versus drugs from multiple class. And the reason why we use like combination at a fixed or low dose, is that it lowers the pill burden and increases the patient compliance. Yeah, so adverse effects. I think there are quite a lot of adverse effects associated with them, as you can see here. That's why this has led to discontinuation and modifications of HIV drugs, and now they can be individualized for the best potency, to increase compliance, for the best tolerability, with minimal toxicity and drug interactions. This is quite important because if these drugs are used incorrectly, such as in the instance of poor tolerance or compliance where patients don't really want to take it anymore, it can lead to multi-drug resistance, which is the last thing that we want. And some predisposing factors to adverse effects associated with HIV are use of other drugs with overlapping and additive toxicities, or certain comorbidities, or drug interactions that may increase the toxicity of either the antiretroviral or the other drug that you're taking. And there's some genetic factors as well. So yeah, resistance. So mutations of reverse transcriptase and protease enzymes has led to resistance of some of these drugs, and once again, this is why we use combination therapies. And there may be resistance to 1, 2, or all 3 major drug classes. This leads to less choice for doctors to use, and long-term treatment is also a contributing factor of high rates of resistance. And some solutions to this is to try and develop new drugs or prevent resistance development in the first place, such as improving patient compliance. And like we said a lot of times now, like combination therapy. And one that's commonly used is triple therapy, such as the highly active antiretroviral therapy called HART, which you may have heard of. And it is a protease inhibitor, or the non-nucleoside reverse transcriptase inhibitor plus 2 other nucleotide reverse transcriptase inhibitors. Yeah, or just in general to reduce transmissions in the first place, so we can educate the people about like stuff like safe sex and stuff like that. Yeah, and we could use antiretroviral therapy for moms and kids to avoid perinatal transmission, so like transmission to the child when the mom is giving birth, stuff like that, or to sexual partners. Yeah, and also the use of prophylactic treatment. So it could be post-exposure or pre-exposure, such as pre-exposure for like sex workers, which is treatment guidelines in general, to doctors to like help them know who to protect. Okay, so lastly, these are the core drugs. So yeah, it's these 5 that you have to remember. I'm a bit uncertain about this one, the tenofovir and emtricitabine, because it is on the core drug list, but there also isn't a page that leads you to it, so I'm not sure exactly if we have to know it, but just know it anyway. Anyway, so I'm just going to start from the top. So acyclovir, it's a guanine analog. So once inside your body, it's activated by infected cells, and its action is to inhibit viral DNA polymerase, and also because it's a guanine analog, it can incorporate itself into the viral DNA, and this causes causes chain termination, as in causes DNA synthesis to end. And it is used in HSV, herpes simplex virus 1 and 2, and varicella zoster virus. So remember, that's what causes like chickenpox and stuff. And its adverse effects are GI disturbances, which is the usual, like nausea, vomiting, stuff like that, diarrhea, or also like some irritation at the injection site. Next is oseltamivir. Hopefully I'm pronouncing that correctly, and this is used for influenza A and B, or also for the prophylaxis of influenza. It's a neuraminidase inhibitor, so if you remember anything about influenza, it is that neuraminidase is like one of the something found on its envelope that allows like budding of the viral, like the new viral particles. So it's an oral prodrug that's activated via hepatic metabolism, and so it binds to this neuraminidase, so this blocks the virus' ability to cleave off of our cells, and this prevents viral release. Yeah, and it's also associated with some GI disturbances, so it's that goes away, or not really goes away, but improved when you take the drug with food. Ritonavir, I think that's how you pronounce it, is a protease inhibitor. So it can be used in 2 different ways. So first, we can use it just as a protease inhibitor, or we can use it as a pharmacoenhancer of other protease inhibitors. So A protease inhibitor just means, well, proteases are obviously enzymes that cleave proteins, and in a viral replication cycle, once the viral proteins have been synthesized, sometimes they have to be cleaved to be activated. So this is what happens. It's what is inhibiting. So it's inhibiting post-translational cleavage of these certain polyproteins, like GAG polyproteins. And so therefore, since they can't be activated, we block the formation of mature virions. So yeah, this just prevents viral replication, as these newly synthesized proteins can't be activated. Yeah, and it can also be used as a pharmacoenhancer of other PIs, and this is because it inhibits this hepatic enzyme that normally is responsible for metabolizing other protease inhibitors. So, by inhibiting this, this enzyme is no longer able to metabolize the other protease inhibitors as quickly. So, therefore, we're able to reduce the frequency and dosing of these drugs, and also reduce the chances of drug resistance. Yeah. So in this case, it will be ritonavir will be taken in subtherapeutic doses. So we use it mainly to block this enzyme instead of its usual functions as a protease inhibitor. And this drug is used for HIV 1 and 2. And it's got an at normal antiviral doses. So in this case, if we're using it as a protease inhibitors, it has like a bunch of adverse effects such as taste changes, paresthesia, anorexia, headaches, dizziness, all of these things. And it's also contraindicated in cardiac conduction abnormalities, such as like I think it was the 2nd-degree AV node block. Yeah. So tenofovir, oh my god, emtricitabine, I don't know. These two, it's used in combination, like it's a drug that contains these two, and it is used in the pre-exposure prophylaxis for HIV. And they're both nucleoside reverse transcriptase inhibitors. So as we know, in HIV, reverse transcriptase is used to modify like the RNA, make it into DNA, stuff like that. And these drugs like target that, inhibits this reverse transcriptase and inhibit viral DNA synthesis. Yeah, but tenofovir, it also inhibits viral polymerase, and also incorporates into the viral DNA to cause termination of like the changing DNA synthesis as well. And tenofovir is associated with nephrotoxicity. Last one is zidovudine. It's also a nucleoside reverse transcriptase inhibitor. So, yeah, it's intracellularly activated, and it also incorporates into proviral DNA by the reverse transcriptase, and then it acts as a chain terminator. And the reason it acts as a chain terminator is because it elects the 3' end for DNA synthesis. Yeah, and its adverse effects are GI effects, and yeah, just the usual. And they're also myelosuppressive. So, that just means like we shouldn't take it with other myelosuppressive drugs. Yeah. So, last week I included the interactions of a lot of drugs, but this week I decided to take them out because looking at them, I was like, I don't think it's necessary to remember those because I never did, and I'm pretty sure never appeared in any exam. So I'm hoping that these are just the more notable ones. And yeah, I think that's it. Thank you guys.
And hi guys, welcome back to another session of PS Pain Relief. I am happy to bring you guys fungal infections. Oh my god, that sounded so bad. I am happy to bring you guys a topic, the topic of fungal infections, as it's a very interesting topic. I actually really like studying this when I was in year 1. I thought it was like really cool to see just the different like gross things, because I think up until this point med has been really like sterile for you guys, you know. It's just like biochemistry, drugs, stuff like that. So it's kind of nice to dig into the really like gross stuff, you know, the really like visceral skin infection kind of things. Maybe I'm just like a weird person. But anyway, I hope you guys enjoyed the Indigenous health thing that I whipped together for you guys today. This week. I know that this week has been a week where a lot of things have just gone on in the world that you guys are probably aware of and not very happy about. So well, yeah, I guess that's just the thing about being human, I guess. Things happen and there's nothing that we can do about it, but we can educate ourselves, which is the whole point of the Indigenous health module that I put together for you guys, and that I really just took from the stuff that we've been learning across the year as medical students. So without further ado, let's get in. So core drugs for fungal infections. These are drugs that there are only 3 drugs, and these are drugs that kind of all are kind of interchangeable. So I'm not going to spend too much time on what kind of drugs you guys need to know, but special treat for you guys is that I have, when I was your age, when I was in your level, I made summary charts for all of the drugs and all of the different infections, which I'm going to try and link. I'm going to try and link it to the Facebook post that I do. If I can, if I can't, I'm just going to upload it to the drive and then tell you guys that it's on the drive. But anyhow, you guys are going to get some summary charts from me that I made for myself, and now I want to pass it on to you guys. So get excited about that. And don't worry if all of these charts kind of seem like a lot to take in. I tried to make it as short as possible, but yeah, we'll see. So there are 3 core drugs that you guys need to know. You also have 3 types of fungal infections. So there's cutaneous, subcutaneous, and invasive. So as you can already imagine, these increase in the severity of the infection. Okay, so onto our, sorry, I just nail polish bottle. So onto our 3 core drugs. We have fluconazole, amphotericin B, and caspofungin. So what you guys should really do is be aware of the class of the drugs, and know that in the exam itself, you guys can be tested on. You guys will be asked like, oh, what kind of drug will work on this. Will work in such a way, and then you'll get a bunch of drugs, and then you'll say, hey, wait, I don't know what this drug is, but because you know that it's also from the same class, or it has the same like suffix as the drugs in this class, you know, okay, if fluconazole, which is an azole, works on that, then this other something azole also probably works on that. So you guys have to just have in the back of your mind that you're not just learning about 3 drugs, you're learning about 3 classes of drugs. So fluconazole is an azole. It's used for sporotrichosis, candidiasis, and cryptococcus, and does not work on aspergillus. So do not use this for aspergillus. Aspergillus is just going to take it in and then shit it back out because it's not going to work. So it targets the plasma membrane by inhibiting ergosterol synthesis, and it's fungostatic. So that means that it just stops the growth of the fungus, but it doesn't necessarily kill off the fungus. And also you should remember that this one is hepatotoxic. So hepato is liver. It causes reactions with the liver. So if, again, they might ask you, they might say, somebody needs to be treated for, let's say, candidiasis, but this person also has liver failure. So what are you going to do? You can, sorry, why is my thing beach balling? Okay, so if they ask you, person with liver failure needs to be treated for candidiasis, you're not going to choose fluconazole, or you're not going to choose any of the azoles, because they are all hepatotoxic, and they're going to stress out this person's already failing liver. So that's why it's also important to kind of know the most distinctive feature about a drug, and then just remember that for the exam. So likewise, amphotericin B, it's a polyene, and it's nephrotoxic. So if you say, again, somebody wants to be treated for candidiasis or cryptococcus, and you're choosing a drug, do not choose, and they have kidney failure, do not choose amphotericin B, because that's going to stress out their already damaged kidneys. Okay, so you kind of can see how this can be woven into the structure of an exam. Amphotericin B disrupts the plasma membrane. And yeah, not too much on that, but caspofungin, it's an echinocardin, if I'm pronouncing it right. It works on candidiasis and it disrupts cell wall synthesis. Both amphotericin B and caspofungin are fungicidal, which means that it actually kills fungi. And you should also remember that caspofungin has GI upsets as one of the things that that is a side effect of it. And by that we mean nausea, we mean vomiting, we mean stomach pains, that sort of thing, predisposition to stomach ulcers, that sort of thing. So here I have a chart, sorry, not a chart, but a more graphical representation of the 3 drugs that I've talked about. So you really should remember that you're not just learning about caspofungin, amphotericin B, and like fluconazole, which is not here. Okay, well, you're learning about echinocardins, polyenes, and azoles. Okay, so you have to remember that these drugs can also be tested, and you're going to have to remember that caspofungin and like micafungin are interchangeable, that sort of thing. So again, once again, cell wall formation inhibition by the echinocardins, cell membrane permeability is destroyed by the polyenes, and cell membrane formation is destroyed by the azoles. And that's on that. So now on to the cutaneous infections. There's really only one that you guys need to know, which is dermatophytes. So here I'm just gonna put little pointers that make the infection a bit more memorable for you guys, and they're a bit more pertinent for you guys to learn. So dermatophytes, they enter in via the skin. So you think dermal, they're a cutaneous infection. So again, dermal skin. And yeah, they also cause ringworm. As you can see, there's ringworm here. And this is jock itch, which is another thing that that is caused by dermatophytes. So really just skin infections, itchy, kind of annoying, and you have to take azole topically. Okay. I actually did have a ringworm infection at one point in my life, like pretty recently, and it's really gross, and I won't get into it, but yeah, topical cream works, and you just don't want to get it because it is itchy. You can't even ignore it, like how itchy that is. Okay, anyway, so subcutaneous infections. The one that you have to remember for this one is sporotrichosis, which is also known as rose handler's disease. So I kind of forgot to put this in the slide, but if somebody says on the exam that, oh, this person is a gardener, and the gardener suddenly has red lesions that pop up on the skin, you know, oh, okay, this person has sporotrichosis, and that's why there are all those like red lesions on the skin. Also, another fun thing to remember that because the species of the fungus is Sporothrix shanky, right? You remember Sporothrix shanky. It sounds like getting shanked, right? So so transmission is by inoculation, which in essence is getting shanked. You know, you're getting stabbed by, let's say, the rose thorns or something that has the fungus on it, something that's like not very clean, and that's how you can get this disease. Now, we weren't given a lot of information for risk factors and pathogenesis, sorry, but yeah, just remember that the symptoms are the red lesions following the proximal lymphatic vessels. So as you can see here, there's a very distinct like line that this path of red lesions are following. It's really not a very pleasant thing to look at. This is already the least gross picture that I could find for you guys. But just remember that, okay, you can see here sporotrichosis, you have like 3 O's in this word, and they're all, you know, so you can kind of think about how the 3 O's in the word kind of look like, you know, the line of red lesions. I know it's a bit of a stretch, but like I'm a really visual person, as you can tell by all the pictures and the charts and stuff like that. And then here, you can also diagnose this by Sarberad's culture, in which I put here, there's a creepy looking black spot with branches surrounded by a white ring. So as you can see here, very creepy. very creepy and also very distinct black spots surrounded by a white ring. And this can be treated by fluconazole and amphotericin B. Okay, and then invasive infections. This is candidiasis. Okay, it is gross. It is very closely related to the appearance of like white patches. So you can have this inside like the GI tract or inside like the if I'm not wrong, like the respiratory tract or something like that. Yeah, and there's white patches on the tongue also. It's kind of gross, yeah. And it's also closely related to immunocompromised patients. So people having HIV, and also people that take IV drugs, and it can also result from very invasive procedures. Yeah, okay, and then just remember that when you see white spots, you kind of think, okay, candidiasis. Okay, and then it can be treated by all three of your core drugs. So just, yeah, not too much about that. Okay, and then I just said invasive infections. Okay, so more invasive infections, remember cryptococcus, right? So it's transmitted by bird droppings. So remember cryptococcus, you know, like a bird, caca. So cryptococcus, okay? Cryptococcus Cryptococcus is transmitted by bird droppings. And as you can see in this chart here, I couldn't really get a picture because most of it is just kind of like, most of the pictures are kind of just like x-rays and stuff like that. But basically the picture here is when you have bird droppings, it goes into your lungs, it lodges in your alveoli, and it enters your CNS, and then it kind of just wreaks havoc upon your nervous system. So yeah, that's not very good. And then you get a positive culture from that, and I'll let you guys read what a positive culture here would look like. And this one can be treated by fluconazole and amphotericin B. And remember, once again, it's a risk factor to be immunocompromised. Being immunocompromised, I mean, you can tell it means that you're at risk of a lot of things. Anyway, another invasive infection is pneumocystis pneumonia. So it's spread by pneumocystis jirovecii. Okay, well, anyway, pneumocystis is again closely related to immunocompromised patients. So if you remember from the previous topics, we were talking about the immune system, the adaptive and innate immunity, and how you know, normally this stuff wouldn't really bother us because we have such strong barriers that prevent us from contracting infections, but people with immunocompromisation, they don't. So remember that because it causes pneumonia, the symptoms are primarily systemic or respiratory. So here, as you can see, there's a long list of symptoms, basically shortness of breath, dry cough, fever is very systemic, cachexia, which is just sudden weight loss. You have chest pains, hypoxia, which is just, you know, not having enough oxygen, rapid crackly breathing, pneumonia, and then lesions in your lymph nodes, your spleen, your liver, and your bone marrow. So these are all very either very systemic or very respiratory systems, okay? And then here you just need to have prophylaxis, and you need to have trimethoprim and steroids. So this is one of the few conditions here that aren't going to be treatable by your three core drugs. So just remember this bit. And we have aspergillus. So aspergillus is not good either. As you can see here, it also damages your lung tissue. Oh yeah, aspergillus is one of the infections that is resistant to fluconazole. Remember that, okay? Aspergillus does not, it takes nothing from aspergillus, it doesn't, yeah, it's not affected by fluconazole. Fluconazole brings nothing to aspergillus. And as you can see on this CT scan, you can see that it's not really good if you have, you know, your lung tissue here and then suddenly a big spot inside the lung tissue. And that's what we call the halo sign, and this is what we call an axial CT. So I'm pretty sure that you guys probably already know this, or maybe have just done some reading if you're particularly interested in this stuff. But axial CT, it's you have to imagine that you're taking a picture of a guy lying down and like the cross section across his like chest this way, and you're looking up from the person's feet. Okay, so this is his left leg, and this is his right leg, and this is the left tissue and the left lung tissue and the right lung tissue. And you can see here very clearly there's a little halo sign there, and that's a sign that this person is having aspergillus. So aspergillus is airborne, but it's also from rotting vegetation. So I guess you can remember it like, you know, aspergillus sounds like asparagus, which is a vegetable, and you get aspergillus from like rotting vegetables. So yeah, it's also something that is common in immunocompromised people. So again, you know, not fun for people. Symptoms. Early symptoms would include a cough or a fever. Late would be pleuritic chest pain and hemoptysis. Okay, so it's a bit complicated for you guys at this stage, but basically pleuritic chest pain means chest pain when you breathe in. Because when you breathe in, your lungs expand, and when they expand, they push on the nerves that are kind of like running along your ribs. So they push against those nerves. They push against the coating, like the membranous coating of the lungs, which is called the peritoneum, right? Your pleura. They push against the line. You basically when you expand your lungs, and if your lungs are already inflamed as is, you will really be pushing on a lot of nerves. You will be pressing the membranous covering of the lungs, and this is going to cause pain when you inhale, okay? Not when you exhale. So that's pleuritic chest pain, and hemoptysis basically means you're coughing up blood. So if there has been a fungal kind of like infiltration of your lungs, then this will probably mean that some kind of blood vessels somewhere are going to be damaged, and this blood is just going to enter your lungs. This blood is going to exit your lungs through your airways, and it's going to get coughed out by you. So that's what happens when you have a lung infection, such as aspergillus. And then mortality, 40 to 90%, not good stats. And it's treatable by amphotericin B. And once again, say it with me, not treatable by fluconazole. So that's it. And yeah, that's all I have. Thanks for tuning in. And I'll send you guys the link with, not the link, but my PDF of all my summary notes. Anyway, bye.
Okay, so that takes us to the next part, being clinical use of antibiotics and antivirals. We'll be running over the antimicrobial creed, what that means. Let's have a look at a couple of antibacterial cases. I'll be running you guys through one, and then we'll finish off with the antiviral hepatitis case. So what is the antimicrobial creed? The acronym is MIND-ME, and the idea is that these are things that you should do if you are prescribing antibiotics in order to prevent antibiotic resistance and the spread of resistance. So M stands for follow microbiology guides. So your indications should be evidence-based. Indications being what things or what tells you should use an antibiotic, whatever that is, should be evidence-based. So it should be based on like, scientific studies and whatnot. N is narrowest spectrum. So the narrowest spectrum should be used for treatment. D is dosage, so individualized dosage, make it appropriate to your patient, to the site of infection and the type of infection they have. M, minimize the duration of therapy. And E, ensure oral therapy is used when appropriate. So basically that's the idea where you want to ensure patient compliance. That's what that's for. Okay, selective toxicity. That refers to the ability of a drug to target sites specific to pathogen. It's the idea that you want to target the pathogen and not any of the human cells and accidentally cause damage and harm to them. How do you do that? Basically, you have to disable a microbial process or a structure so that your pathogen can't work the way it's intended, or you can target and inhibit a pathway or a target critical for pathogen survival and replication. In terms of common targeted sites, I think we would have mentioned them in antibiotics, but yeah, common target sites: cell membrane, cell wall, the pathogen's ability to metabolize folate, that's essential for survival, protein synthesis pathways, as well as nucleic acid synthesis. In terms of what would cause successful antimicrobial drug therapy, you'd have to have a look at two things. You've got to look at drug pathogen factors as well as drug patient factors. Drug pathogen means, what's a drug spectrum? Are we using a wide or narrow one? Does this type of pathogen have that kind of resistance to this family of drugs yet? Yes or no? And does the drug kill the microbe, or does it just stop growth? Is it bactericidal or bacteriostatic? That's another thing you can take into account. And then you have a look at your drug patient factors. What's the route of administration? What's the dosage? What's the frequency? And that's also something which can benefit with patient compliance, and if that's going to be easy and achievable for your patient. In terms of reducing antimicrobial resistance, follow the creed, antimicrobial creed, mind me. So use antimicrobials when it's necessary. Don't use them when you don't need them, right? Choose the right drug. You want to find the most narrow spectrum possible, most effective against that pathogen. And really important to carefully consider your dose and duration of treatment. In terms of some links to use when you guys go through these cases in your active learnings or your online modules, click on the ePharmacology med Monash kind of page, and on the right hand side it has these two links for the e-therapeutic guidelines and the AMH that just gives you the proxy so you have access to it. E-therapeutic guidelines are used to search up conditions, and it will tell you like the guidelines for like prescribing, and like if the person's pregnant or if the person has allergies, what do you do? If they're young versus they're old, what's the dosage? It's quite helpful. And that's like, you don't make stuff up, you just follow the guidelines, have a read of them. It's really key. Make sure you use them. So I would like search up, like, if it's a water-based infection, I search up water, click something which is related to infection. I might narrow the search down by clicking antibiotics. If I know I'm looking at antibiotics, it is really helpful. And then AMH tells you about the mechanisms of action. So if you know what drugs you're supposed to be using, you can search it up. It has the handbook, and it has like based on the name of the drugs, search it up, see what that drug does. And it will fall under one of the families. But yeah, use the guidelines. I didn't. It made life hell. Just use them. It's so much easier. So what I'll be doing is I'll run through an example case. I'm not sure if you guys will or will not get this case, but I'll run you through it, how to use it, and obviously make sure you use all the links and whatnot. So a mother takes her 8-year-old daughter to the local GP clinic. The child has a fever, 39.2 degrees Celsius, very painful earache, and has been vomiting overnight. An ear examination shows that the eardrum is red and swollen, and we note that the child has penicillin allergies. When we go through a scenario like this, there's a couple things to keep into mind. And first of all, you just have to think, you brainstorm for a little bit, right? They've got a fever, so we're looking at like a systemic, systemic meaning it's affecting the whole body. Very painful earache, so it's probably localized. We're looking at some sort of pathology in the ear, something related to ear, yeah, and vomiting overnight. So that's another systemic feature. So we're thinking, okay, so she's got a fever, red and swollen. Is this an infection, right? So we've got an infection, you've got the redness, you've got the swelling, and you've got the systemic symptoms being that fever and the vomiting overnight. She's got a very painful earache. It's probably a localized ear infection. And another thing not to forget about is that penicillin allergy, because that's going to have an impact on whatever prescribing or whatever drugs we do. Anyways, so we've narrowed it down. We're thinking she probably has an ear infection, and it's systemic because there's some other symptoms associated with it. Where do we go from here? Hop onto ePharmacology. You go into the e-therapeutic guidelines. Looks a bit like this, ETG, therapeutic guidelines. And I'd search up, like what is an ear infection? It's otitis. And then I search up otitis, and it gives you otitis media and otitis externa. Which one is it? Well, we've been told that there's a very painful earache, and the ear examination shows that the eardrum is red and swollen. If the eardrum is red and swollen, that's going to give us a hint as to where in the ear do we have the infection. Is it the external ear, middle ear, or whatnot, right? So if it's eardrum, then that actually narrows it down for us, and that tells us it's otitis media in the middle ear, and we know it's systemic complications because we've also got that vomiting, that fever. Okay, so what we do, we click on the otitis media link. I've also, it's this one right here, but I've also hyperlinked it in case anyone finds difficulty finding it, and you can hop onto the site and like directly direct yourself about it. And then when you scroll through, so I'll show you guys what the guideline looks like if you follow the link in a little bit. It will show you, first line therapy, drug class, and you can find out the mode of action by hopping onto the Australian Medical Handbook, searching up like amoxicillin or sulfuroxime, and it'll show you the mode of action, which I'm sure was covered earlier to you guys. So yeah, the example they've given us, and I'll show you it a little bit, was amoxicillin, but that's a type of penicillin. With this child, we can't use that. So instead we're using sulfuroxime. I don't know if I'm saying it right, even, to be honest, but it'll tell you in the guideline. You just scroll through and you read, and that's actually in the cephalosporin drug class, and that one is responsible for cell wall synthesis. So it's in this family here, and more specifically, it's the cephalosporin right there. But yeah, let's hop onto and follow this link. So what would that kind of look like? So we're following with this case. We've searched up otitis media and we've clicked on the otitis media link. Now it gives you a bunch of different drop-down menus what you want to read from. To answer these questions, so what's a diagnosis? I think we've already got that. What's a first-line therapy? We have a look at the antibiotic regimens for acute otitis media. You click on that and it'll show you this, antibiotic regimens. If antibiotics are indicated, so if they're needed, it's amoxicillin, and that's kind of the different dosages and whatnot. And it takes into account like adherence. It takes into account like almost everything because it is a therapeutic guideline. It's nice and nifty here because it says PBS as well, so I think that's quite helpful. And then we remember the child has a penicillin allergy. We can't be giving them amoxicillin. We scroll down and we have a look. Oh, if there's a delayed non-severe hypersensitivity to penicillins in place of amoxicillin, you'd give sulfuroxime or trimethoprim sulfamethoxole. But that's your answer, yeah? And then you'd hop onto the Australian Medical Handbook. You can search up, this drug, maybe these two as well if you want to find out their mode of action. It's a cephalosporin, cell wall synthesis, kind of like what we've mentioned here. So cephalosporin, and it affects cell wall synthesis, and that would show up when you hop onto the Australian Medical Handbook. I've got the link from earlier. Use write in like sulfuroxime or cephalosporins. They'll give you the answers there. All right, so that's kind of an example of how you go about a case. You'd have a look at the scenario, try to do a little bit of thinking, a bit of deduction, and then you can literally just hop onto the therapeutic guidelines, search something up. It'll give you the guidelines and explanations and recommendations for treatment. It's really quite helpful. And the Australian Medical Handbook will tell you guys the mode of action for your specific antibiotic or whatnot. Now, there's a couple other cases. I don't know which ones you guys have, and if they give you solutions or not, I'm not really sure, to be honest. But I'll run you through quickly a couple of these. Now, I'll kind of just summarize it and kind of the idea that you have to do, and you guys can obviously read this in a little bit more detail later. So in this case, we've got a 72-year-old woman. She's gone to hospital, cardiac disease, right? Her health is clearly falling. She's again got that systemic fever, 38.9 degrees Celsius. She's got shortness of breath, productive cough, so a bunch of symptoms. And when she coughs, she has pleuritic pain. Oxygen therapy, infiltrate is apparent in her X-ray, and infection with multi-drug resistance is the fear. So we're looking at multi-resistant Staph aureus. Potentially. So what do we think when we have a look at this? You try to deduce, she's been in the hospital. She's probably got this from the hospital. So it's probably hospital-acquired nosocomial. She's got confusion, fever, shortness of breath, productive cough, pleuritic pain, as well as infiltrates on her chest X-ray. And also the fear of multi-drug resistance. What do we do when there's multi-drug resistance? Follow the guidelines, recommendations of what you do when there's multi-drug resistance. But the diagnosis here was methicillin-resistant staphylococcal pneumonia. So she probably has pneumonia, because she's got infiltrates in her lungs, and she's got a really productive cough, and shortness of breath, and it's an infection. So it would make sense that it'd be pneumonia because she's got that fever as well. You search up, staphylococcal pneumonia. It'll give you tab options for methicillin resistance and whatnot. Have a look at the first-line therapy, and this is just a screenshot from the therapeutic guidelines, vancomycin or linezolid. You'd hop onto Australian Medical Handbook, and it'll tell you the drug family. So this one targets cell wall synthesis. But I don't know if I were you guys, search up vancomycin and linezolid. Obviously, it's one or the other, but search those up in the Australian Medical Handbook, and it will tell you how it works, what it does, what drug family it belongs to. Same thing here, we've got another case, 26-year-old woman. She's 12 weeks pregnant, burning pain, urinating. Okay, so 12 weeks pregnant, burning pain, urinating, urinates more often, so frequent urination, and pain above pubic bone. She started on empirical therapy and given pathology to give a midstream urine specimen. What do? Well, she probably has an acute cystitis, so that's essentially a UTI. But what's important to notice is she's also pregnant. So what do we think? What do we do? Well, we search up acute cystitis, and it gives us acute cystitis in adults, in children. You go within adults because she's an adult, right? 26. You follow that, and it tells you the investigations. Well, you read through, and in one of the tabs, you'll find investigations for acute cystitis in adults, which makes sense because they've asked her to follow investigation, right? They're sent pathology to provide a midstream urine specimen. So what are they doing? Oh, pregnant women. That's exactly what we want. We follow that link, takes us to acute cystitis in pregnancy, and it gives you the kind of drugs you should be using here for acute cystitis in pregnancy. But yeah, with this, it's all about reading the guidelines. Yeah, it's all about reading the guidelines and just following the tabs and links they have. Those are really there to help you. Now, this cephalaxin and cephalosporin are for non-pregnant women. So for her, acute cystitis in pregnancy, she'd need nitrofurantoin or cephalaxin as well. But whatever it is, follow through on the ETG, e-therapeutic guidelines, and it'll help you there. You know, you read through it. There's quite a lot of tabs, but it's quite easy to understand. In that, like, it's not too difficult. It's like, if there is this, do this. And you can notice it's really quite helpful. You see the pregnant lady there? The symbol, it tells you it's safe to use in pregnancy. So I thought that was super neat. Okay, so that's it with our antibiotic cases. You guys can look through those, give it a go, hopping onto like the therapeutic guidelines if you want to like skim through those, or do the same thing for your own cases if they're different. But next one we're looking at is antivirals, and this is the clinical use of antivirals. In this case, we're looking at Hep C. So I've got a lab tech, chronic Hep C, no symptoms, but he has some blood splashes, needle stick injuries. Again, healthcare workers, you got to be careful with the hepatitis. When you ask about occupation, that's actually one of the examples where asking about occupation is really quite relevant because of the risk of needle stick injuries. Non-smoker, drinks beer, medications, sexually inactive. He has had a Hep B vaccination. Liver enzymes are elevated. HCV RNA viral load indicates the amount of circulating virus has increased. Genotype identifies it as type 3. It's giving you a bunch of information here. So really, as soon as you get a prompt like this, you'd really want to hop onto the therapeutic guidelines and see what they say, because there's a lot of detail they've mentioned here. Post-normal time is normal. That's an indicator of how well your liver's working, you know, how long it takes for your blood to clot. HIV serology shows negative. Liver biopsy shows chronic inflammatory infiltration of the portal areas with minimal fibrosis. So little scarring, but he's got chronic inflammation. What's the idea? We're looking at HCV antiviral therapy here. The first question for us, I guess, was what's the goal? The goal was to prevent progression of hepatitis disease and eradicate the virus, as well as some other smaller ones, preventing occurrence of liver-related complications, for example, fibrosis. And if the liver is fibrotic, you'd want to reduce the hepatocellular carcinoma risk. So you want to decrease the risk of getting liver cancer. That's the goals of the therapy. In terms of what we're kind of looking at more specifically though, you'd have to hop on. I've got a lot of screen grabs here. It's a bit messy, but this is just the last bit. We'll power through it. You have a look, you search up, hepatitis C. You have a look at like acute hepatitis, chronic hepatitis, whatever, and it'll give you like examples of direct acting antivirals, how they work, so protease inhibitors, whatever inhibitors they use, and those are part of the anti-HCV therapy with examples there. And then you look specifically for Roshan, our case, antiviral regimen for an adult with hepatitis C. It like gives you the regimen, the recommendations, whatnot. You don't need to come up with that on your own. It even gives you, this is what I do. I just do Control F considerations, because I think in the active that asks what considerations do you need to take. Control F considerations. Read through the considerations. That's really helpful. And then last of all, here we've got just some explanations of what these drugs do. But again, the whole idea is your cases might be different, but the thing I want you guys to pick up is how to use these guidelines, how to navigate the e-therapeutic guidelines, and use your Australian Medical Handbook to set up the mode of action for these, because that's how clinically they'll use antibiotics and antivirals. You know, search up your condition, and even if you're not 100% sure, search up some of the key terms or whatnot. And eTherapeutic Guidelines has that really useful search function, which can let you skim through results, have a look for just antibiotic usage, even if you're not sure of a diagnosis. But that kind of wraps up how we clinically use antibiotics, antivirals, and I guess the main takeaway is a little bit of deductive reasoning is what you need. You don't even need the full diagnosis from the beginning. You just need to know the vague idea what the condition might be. You pop it onto eTherapeutic Guidelines, and that can help narrow it down for you, you know, based on the patient type, population. Are they young? You know, are they children? Or are they not normal adult age? Or are they elderly? Is it pregnant woman, non-pregnant woman? You know, it even separates it, like for the UTI, acute cystitis case, it's separated for like males and then non-pregnant females and pregnant females. It really goes into it, you know. Does your patient have a penicillin allergy or not? You know, based on your patient's allergies. It's all there on the therapeutic guidelines. You just have to read through. It takes a bit of time, but you read through, you click down the tabs, and it really tells you what you need to do. That's the beauty of it. And then you hop onto your Australian Medical Handbook. Once you know what kind of drugs you want to be using, search them up in there in the directory. You can just go by based on like the spelling, you know, what they're called is based by name. And that'll tell you the mode of action, how the antimicrobial works. And that's kind of how you approach these cases. Hopefully that's helpful. Now, if you guys do have any questions or whatnot, otherwise it'd probably be helpful if I pop in my email. That's my student code. If you have any questions, do send them my way. So at student.monash.edu. More than happy to hear anything, answer any questions and clarify anything. Alrighties, I'll leave that there.